Welcome everyone, my name is Wafa. I'm the tutor for MRCOG Part 3 Circle. So we just specialize in MRCOG Part 3 exam and preparing candidates for the same exam. Okay, some of you may know me, some of you may not. So I've been tutoring for the Part 3 since 2018. We do frequently every now and then free sessions, and also they're posted on our YouTube channel as well, on our Facebook page and Facebook group. We also have a dedicated Telegram group. I'm also a co-author in the Part 3 book. If any of you didn't go through it yet, I would strongly recommend you go through that book. It's a really, really good book for the Part 3, and it's the main author is Professor Konji, and it does have a lot of cases for the Part 3, especially a lot of information regarding how to prepare, and a dedicated chapter on fetal medicine. Okay, so I would really recommend that book, in addition to other books, which is basically the Lisa Joyle Part 3 book, which is made by the Royal College itself. Okay, so I've put together today in this session 4 cases, different case scenarios, and it was specifically for those who are just starting to prepare and don't really know how to go about cases. So I've started with simple case scenarios, and then we would go on to a little bit more complex scenarios in terms of communication. I would require some volunteers. Don't worry if this is the first time you're going to do a case scenario, because at the end it's just about practicing. Okay, and I'll try to help you throughout. So our first case scenario is going to be this one. I'm going to read it out, okay, and explain what needs to be done, and then we're going to go through the guideline related to this case scenario, just to show you how you can extract information from the guideline that will help you in your Part 3 preparation, because it's completely different from the way that you prepare for the Part 2. And when we advertise for this session, I did recommend that you go through one of our previous sessions that was done a couple of months ago regarding how to prepare for the Part 3, so it can just be a continuation. So let's read the case together. So usually I have on top here, to the top left, your candidate instruction. Beneath that, you will know what type of case scenario you're going to do. So this is a simulated patient task, meaning you're going to see a patient, you're going to talk to that patient, okay? If they say this is a structured discussion task, that means you're going to discuss a case with the examiner. If it's a simulated colleague task, it means you're going to do a teaching scenario. And the simulated colleague task is only one case out of the 14 cases in the Part 3 exam. Below that, you will have your domains. Here, I've put all the 5 domains just for teaching purposes to see how we can cover them. But in the exam, you'll have 3 to 4 out of the 5 in each case. You wouldn't find all the 5 domains there. So the 5 domains are information gathering, communication with patients. So information gathering is basically the history you're going to take, the examination you're going to do if it's required, okay? Communication with patients is your communication with the patient in terms of involving the patient with you throughout, having a good introduction, creating rapport with the patient, checking what they understand so far about what's going on, using layman terminology, which is patient-friendly terminology and not medical jargon, drawing if it's applicable, and inviting questions in between, and at the end coming up with a summary if you do have time, okay? Our third domain is patient safety, which is basically the most important domain in the exam, and it's the most important domain in our clinical practice, because at the end, the patient is coming to you for treatment. You want to ensure that you are giving the right treatment for the right patient. Okay, that's under safety. You want to ensure that you are giving her treatment or option that is safe for her and not risking her safety. And last point is making sure that she understands all the risks and the complications associated with the options you are, or the treatment you are offering her, because based on that information, the patient is the one who would make her choice, what she would like, okay? Fourth domain is applied clinical knowledge, which is basically your knowledge, is it updated to the latest guideline or not? and it's correct. Fifth domain is communication with colleagues, which is basically thinking about who would you want to involve in this patient's care apart from yourself and the consultant. Okay. Now, the scenario is you're the ST5 in the gynae clinic, so you know who you are. In the exam, you're always the ST5. You know where you're posted. So you're in gynae clinic today. Your patient is Rebecca Clark, 50 years old. She's been waiting for an hour, over an hour for her appointment. So there's a delay in seeing her. And usually that happens when you have a busy clinic. Okay, because usually we try to see patients on time. They would be aware of what time exactly their appointment is, and they will come around that time. So if there's any delay in seeing them, usually it's a nice approach to just apologize for the delay. Okay. She has a BMI of 40 and a history of heavy menstrual bleeding for 1 year, which is not responding to mefenamic acid and tranexamic acid. Yes, she's 50, but it's clear here that she's still continuing to have her period. So it's not a case of postmenopausal bleeding. Initially, an ultrasound scan was done 3 months ago, followed by an inpatient hysteroscopy, polypectomy, and endometrial biopsy, and that was done 3 weeks ago. So part of her workup for her heavy menstrual bleeding. So let's go backwards. What would happen is that she will go to the GP, telling the GP, I have heavy bleeding. Sometimes the GP can initiate treatment. If she doesn't respond, they refer her to the gynae clinic. Okay, other GPs just refer immediately. So she comes to the gynae clinic, she would be assessed, she would be seen, and in this case, she was offered an ultrasound scan, and you have the result of the scan. So the scan that was done 3 months ago, if you look here in the box to your left, pelvic scan, it has the date, the name, and the age of the patient, just to confirm that it is her scan and no other patient's scan. The uterus measures 48 by 28 by 36 millimeters. Endometrium measures 25 millimeter in thickness towards the fundus. Query, is there a polyp? There's a 3 by 3 centimeter subserosal fibroid, which is completely irrelevant here. Okay, so not every finding is relevant. Okay, normal right and left ovary, so there's no ovarian pathology, no free fluid in the pouch of Douglas or any masses in the pelvic area. So that scan that was done 3 months ago identified a thick endometrium, query, and endometrial polyp. That could explain her menorrhagia. Now, based on that, she was consented for an inpatient hysteroscopy, polypectomy, and endometrial biopsy. Sometimes that can be done as an outpatient, but again, it depends on the patient's decision or choice, whether she wants it to be not under anesthesia, just some pain relief and all gas and air, and her to be awake. That's possible, or it can be done under GA. Sometimes patients are anxious and say, no, I don't want to be awake. So they choose for it to be as an inpatient procedure. Okay. Now, when she had the hysteroscopy, polypectomy, and endometrial biopsy, that was done 3 weeks ago, the result of the histopathology came out. You have the date, you have the patient's name and age as well. And just let me pause the screen. Yeah. You have the sample as an endometrial biopsy. Microscopy shows fragments of proliferative endometrium, crowded glands, in keeping with hyperplasia without cytological atypia. There's also evidence of stromal condensation, no evidence of malignancy. So in summary, the histopathology results of the endometrial biopsy shows endometrial hyperplasia without atypia. Ideally as well, you would have the result of the polyp. Okay, so let's just say that the endometrial polyp was a benign one. All right. So some people, when they read a scenario like this, they will go, okay, they start with explaining the scan findings and then explaining the histopathology results. But again, look at the sequence of events. She had the scan. After the scan, she was seen. That's why, or that's at that appointment after the scan, she was booked for a hysteroscopy and endometrial biopsy. And of course, she would be consented. So you would be thinking in the 2 minutes that, okay, the patient knows about the scan results. She knows about the procedures that she had. She's now here to discuss the histopathology results. Okay, so I've written here, she has this appointment to discuss the histopathology results. Now look at the bottom. You have 10 minutes during which you're expected to inform the patient about the result. Number 1, take relevant history and formulate management plan and address the patient's concerns. I hope all of that is clear to now, everyone. Okay, so when you start off a case scenario like this, I always advise that check the patient's understanding about her condition so far. Okay, so you and the patient from the beginning would be on the same page and you take it on from there, right? Some people will start their introduction by closing everything off the same. So I'll give you an example. Hello, my name is Wafa. I'm one of the doctors in the gynae clinic today. Can I just confirm your name and age, please? Is it okay if we call you Rebecca? Please call me Wafa. How are you doing today, Rebecca? I understand that you had heavy bleeding and you were taking medication. It didn't work. Then you had an ultrasound scan. It showed this and this. After that, you had a procedure. It showed, and you're here to discuss the results. Am I right? Now, that's a way in which some candidates would prefer to do it, but I wouldn't. It's not wrong, but I wouldn't advise it, okay? Because you can see here, I've been talking for a whole minute till now, and just the patient will say, yes, that's right. And then I go on either to take history or explain the results. Sometimes there can be something hidden that I didn't pick up, or sometimes the patient may not be understanding from the beginning what was a polyp, okay? You never know. So I wouldn't assume. So instead of doing that, I'll do it in another way. So how I'm going to start. Hello, my name is Wafa. I'm one of doctors in clinic today. Can I confirm your name and age, please? Is it okay if I call you Rebecca? Please call me Wafa. How are you doing today, Rebecca? I'm doing fine, thank you. Right, that's lovely. And so Rebecca, because this is the first time I've seen you, I understand that you've been seen here before and you even had a procedure. So in your own words, can you tell me what you understand about your condition so far? All right, so I would let her confirm for me the information that is in front of me. Okay, this is the best way to start off any case scenario where you have a patient in front of you. After she tells you the whole story, you would be listening. The examiner would give you marks, would be giving you marks during that time, because from the beginning you're involving the patient, and that's under communication with patients. Plus, the first few minutes in any case scenario, in those few minutes, the examiner would be making an opinion regarding you, okay? And if you impress the examiner in the first few minutes, they will say, okay, that's a good doctor. They're communicating really well from the beginning. They're involving the patient in the care, all right? So that's why we usually advise to start off this way. Now, after that will come your history, you explain the results and your management plan. Here you would be communicating with patients as well, but you would be showing your applied clinical knowledge and patient safety. Now, all of you, since you've done your part too, you would know the management plan of endometrial hyperplasia without atypia. But before we start the case, just let me open here. I've extracted this from the guideline. Wait a second. Okay, so let's go through this before I ask someone to do the case scenario. Okay, so it's mentioned here, so we'll just read it out together just to recap the applied clinical knowledge and see how we can explain that to the patient and what amount of information we're going to extract from here to explain to the patient, okay? So what diagnostic and surveillance methods are available for endometrial hyperplasia? So diagnosing endometrial hyperplasia requires histological examination of the endometrial tissue. Endometrial surveillance should include endometrial sampling by outpatient and endometrial biopsy. And diagnostic hysteroscopy should be considered to facilitate or obtain an endometrial sample, especially where outpatient sampling fails or is non-diagnostic. So sometimes you would do a PIPL biopsy in the clinic. Some patients do agree and you obtain a sample, Okay, now some patients will tell you, no, I don't want to, or once you start doing the PPL, they're in pain, they ask you to stop. Whenever they're in pain, they ask you to stop, you stop, you don't continue further. Okay, so sometimes you can have a result of a PPL biopsy, and if the PPL biopsy couldn't be tolerated, you couldn't go on further, or the result comes as non-diagnostic or non-conclusive, you couldn't obtain enough sample for it to be analyzed, then you would do a hysteroscopy. So in the exam, you can find either or, because it usually depends on what the patient agreed to have, whether a PPL biopsy or a hysteroscopy that can be outpatient or inpatient. Okay. Third line, transvaginal ultrasound may have a role in diagnosing endometrial hyperplasia in pre and postmenopausal women. Okay, so you can have a scan or you may not. Direct visualization and biopsy of the uterine cavity using hysteroscopy should be undertaken where endometrial hyperplasia has been diagnosed within a polyp or other discrete focal lesion. So sometimes a patient may just have a hysteroscopy and polypectomy done, and then when you find that in the histopathology results of that polyp, when it comes back, it may show endometrial hyperplasia, then you would take her in for an endometrial biopsy or sampling. Okay, but lots of the time, what is done is that instead of doing two procedures, since you are going to do a hysteroscopy and polypectomy, take a biopsy at the same time. It will just save time. That's why in our procedure, the patient was consented for hysteroscopy, endometrial biopsy, and polypectomy. Okay. There is insufficient evidence evaluating CT or MRI or biomarkers as aids in the management of endometrial hyperplasia, and their use is not routinely recommended. So based on this information, you're not going to tell the patient, okay, we can do an MRI or a CT scan. Or if the patient asks you, sometimes they can prompt you, can I have an MRI? Okay, they must have read about it somewhere. In that case, you would use what is mentioned here in the guideline. That no, there's the evidence say it wouldn't, or there's not enough evidence to say that it would help us, okay, or give us further information. Now, that top part is regarding the diagnosis. Okay, what should the initial management of hyperplasia without atypia be? So women should be informed. Whenever in a guideline you see that line where they tell you the woman should be informed or should be told or should be aware of, that means you have to mention that information to the patient during your counseling. So women should be informed that the risk of endometrial hyperplasia without atypia progressing to endometrial cancer is less than 5% over 20 years, and that the majority of cases of endometrial hyperplasia without atypia will regress spontaneously during follow-up. So you're going to automatically extract that paragraph and explain it to the patient. Okay, that would be when you explain to her what the biopsy shows, what is endometrial hyperplasia without atypia. Okay, reversible risk factors such as obesity and the use of HRT should be identified and addressed as possible. Now here, that is under information gathering. So in your history, if it's not mentioned to you whether she's taking HRT or not, and you see that her age is around the menopause, then ask her. So these are one of the points that you will ask on the history. Not all the history points will be mentioned in a guideline, but sometimes they mention the relevant important points. And these relevant important points would be most probably one of the points in the examiner's marking sheet that has an asterisk mark that you should not miss it at all, or otherwise they're going to mark you down. Okay, BMI. I see a lot of candidates asking patients, like when in the course when we're doing a case scenario, they ask me, do you know your BMI? I tell them no, because patients don't know. Most of the time they don't know their BMI. If you ask me about my BMI now, I'm not really sure about what my BMI is. Okay, you have a nurse with you. If it's not mentioned there in the case scenario, it's part of the examination. So okay, I'll just ask the nurse to check your weight and height so we can calculate your BMI. All right. Okay. Now, if you go to the third paragraph there, observation alone with follow-up endometrial biopsies to ensure disease regression can be considered. So that's one of the management options. Okay, when you come to your management plan. just observation with endometrial biopsy, especially when identifiable risk factors can be reversed. Like, for example, if they're diabetic and they're not controlled, that's a risk factor. If they have a high BMI, you can start controlling that. If they have PCOS, polycystic ovarian syndrome, if you start treating that, then that can help. So these are, when you have risk factors that you could identify for the endometrial hyperplasia, you can start her on conservative management, okay, with biopsies. However, women should be informed that the treatment with progesterone has a higher disease regression rate compared to observation alone. Now, again, they're telling you women should be informed, so you should tell her this point. So when you tell her about that, so when you come to the options, you tell her, so in terms of managing you, we do have a couple of options, okay? We can either observe and follow you up and then take regular samples from, or biopsy samples from your lining of the womb and see if it would, regress and become not, or we have normal results. The second option is we can start you on medication, which is hormonal treatment. Hormonal treatment, comparing it to just following you up, has a better cure rate than this follow-up. Okay, this is how you can explain it. So that's how you're comparing options to each other so that the patient can, understand, okay, progesterone is better than waiting. Okay, I wouldn't mind taking progesterone, because some women would refuse any treatment. They don't like hormonal treatment at all, especially the Mirena. Okay. Progesterone treatment is indicated in women who fall to regress following observation alone and in symptomatic women with abnormal uterine bleeding. Now, they've mentioned an indication for when you would not prefer observing the patient without giving her any treatment and just following her up. That's if she has abnormal uterine bleeding. So in our case, this patient does have menorrhagia. So in that case, you're going to prefer management over just observation alone. Okay? All right. What should the first line medical treatment of hyperplasia without atypia be? Both continuous oral and local intrauterine progesterone, which is a Mirena coil, are effective in achieving regression of endometrial hyperplasia without atypia. So here your notebook, when you're reading the guideline, you're right, okay. If we just want to recap what we've read and what information you want to write in your management. So you write management of endometrial hyperplasia without atypia. Number one, observation with follow-up or biopsy follow-up, and then just write the condition if the patient is not symptomatic and not willing for hormonal treatment and she has identifiable risk factors that can be controlled. Okay. Number two, progesterone. Okay, either Mirena coil or oral progesterone. Okay, and that you can write on top for women who are symptomatic, between brackets, or i.e. having menorrhagia or irregular periods. All right, so that's how I'm just showing you bit step by step how you can have your notes or summary from the guideline for the part 3. Okay, now the Mirena should be the first line medical treatment. Now they've said it clearly, first line. So when you start with your medical options, don't start with oral progesterone. Start with the Mirena and mention it clearly to the examiner. Our first line option would be the Mirena. Okay. So the Mirena should be the first line medical treatment because compared with oral progesterone, it has a higher disease regression rate with a more favorable bleeding profile and associated with fewer adverse effects. You could use that in your counseling when you're taking her through the Mirena and the oral progesterone and comparing them to each other. Continuous progesterone should be used, which is medroxyprogesterone acetate, 10 to 20 milligram per day, or norepinephrine, 10 to 50 milligram per day, for women who decline the Mirena. So you're going to talk about the Mirena, explain how it's going to help in the period, briefly explain what are the side effects of the Mirena, and the follow-up. And then after you finish, ask her, do you have any question? And then you tell her we have a second option if you do not wish to have the Mirena coil inserted, which is taking the same hormone as tablets, but. And then you tell her what is the difference between the oral progesterone and the Mirena, why you favor the Mirena over the oral progesterone. Okay, tell her it's less effective, and also it has more side effects because the hormone is going through your bloodstream, while in the Mirena coil, and only a fraction or a small amount of hormone goes to your bloodstream. Okay. Cyclical progestogens should not be used because they are less effective in inducing regression of endometrial hyperplasia without atypia compared to continuous or oral progesterone or the Mirena coil. So when you talk about the oral progesterone, tell her you'll take it throughout the month, every single day. Okay. Now, what should the duration of treatment and follow-up of hyperplasia without atypia be? Treatment with oral progestogen or the Mirena should be for a minimum of 6 months in order to induce histological regression of endometrial hyperplasia without atypia. If adverse effects are tolerable and fertility is not desired, women should be encouraged to retain the Mirena for up to 5 years, as this reduces the risk of relapse, especially if it alleviates abnormal uterine bleeding symptoms. Endometrial surveillance incorporating outpatient endometrial biopsy is recommended after a diagnosis of hyperplasia without atypia. And endometrial surveillance should be arranged at a minimum of 6 monthly intervals. Okay, and at least 2 consecutive 6-monthly negative biopsies should be obtained prior to discharge. So when you read this in the guideline, so you can see here that they have talked about the Mirena at the beginning a little bit, and then the oral progesterone, and then after that, you talked about the follow-up for the Mirena. When you're counseling a patient, you're not going to do it in that order. You're going to extract all the information about the Mirena, put it together, and give it to the patient so you don't confuse her. And then after that, all the information about the oral progesterone, put it together, and tell it to the patient. So when you talk about the Mirena coil, again, I'll recap. You have to make sure to tell her that it's the first line recommended management option, okay, and how it works, what are the side effects, and how would the follow-up would be. Okay, so tell her it would be for a minimum, we recommend 6 months for us to see the results and the cells becoming normal again. And we will bring you in for an endometrial biopsy, okay, at least every 6 months. And if you do have further heavier bleeding or new symptoms in terms of irregular periods, we would see you earlier than 6 months. And I tell her if you're coping well with the Mirena coil, then we would recommend you leave it for a maximum duration of 5 years. We can discharge you from follow-up with us if we have 2 samples that are normal. After that, you can just follow up with the GP and keep the Mirena coil in place. Okay, ask if she has any questions, then you go to the oral progesterone. Now let's go to the, sorry, because I just need to go on the next page. Yeah, this one. Sorry, I need to just enlarge it. Yeah. Okay. So where did we stop? We stopped here. Women should be advised to seek a further referral if abnormal vaginal bleeding recurs after completion of treatment, because this may indicate disease relapse. So that means safety netting her, not just telling her, okay, once you have 2 negative biopsies, we'll discharge you, we'll keep the coil for 5 years. After that, like after 2 negative samples, we don't need to see you again. You can be discharged back to the GP. No, you have to safety net her. Tell her when, after she's discharged, when she should come back. If again, heavy bleeding comes back again, so relapse, or she has new symptoms in terms of, let's say, irregular vaginal bleeding. Okay. In women at higher risk of relapse, such as women with a BMI of 35 or greater, or those treated with oral progesterone, 6 monthly endometrial biopsies are recommended. Once 2 negative endometrial biopsies have been obtained, then long-term follow-up should be considered with annual endometrial biopsy. Now here you have an exception from the follow-up that we just talked about earlier for the Marina. Okay, so the follow-up, if she's going to have oral progesterone, is going to be different. She's going to have 6 monthly biopsies, but you're not going to, after 2 negative biopsies, you're not just going to discharge her back to the GP with no further biopsies like in the Marina coil of everything's fine and safe to letting her know. After 2 negative biopsies, she would need yearly endometrial biopsies. Okay, if she's going to have a Marina, but her BMI is 35 or more, like our patient, her BMI is 40, then again, the follow-up would change. You will talk about the long-term follow-up with annual endometrial biopsies. Okay, and of course, you're going to advise her to reduce her BMI because that's one of the risk factors that you can control and can help in the disease regression. Now, when is surgical management appropriate for a woman with endometrial hyperplasia without atypia? Hysterectomy should not be considered as a first-line treatment for hyperplasia without atypia. I've seen some candidates who, once they find that the patient is around the age of 50, she's completed her family or she's postmenopausal, they'll say, okay, let's take everything out. Let's take her for a surgical procedure. No, clearly mentioned it's not first-line treatment. Since there's medical treatment, guideline clearly mentions medical treatment, regardless of what her menopausal status is, stick with the guideline. But in the NHS, if there's no indication for a surgical procedure, it will just increase the costs for the NHS, and also it's associated with complications. You never know what can happen on table. So if there's no indication for a procedure, it is not done. Okay. So there is conditions where you would offer surgery. Okay, so I will read that again. Hysterectomy should not be considered as first-line treatment for hyperplasia without atypia because progesterone therapy induces histological and symptomatic remission in the majority of women and avoids the morbidity associated with major surgery. So you can use this bit if the patient tells you, can't I just have my womb removed? I don't need it anymore. I've completed my family. I'm 50 years old. For you to answer her, you would use this bit. Okay, so tell her that we don't usually offer a hysterectomy in the first instance. We try the hormonal treatment. In most of the cases, it will work. In case it doesn't work, okay, then we would go ahead with the surgery. Just because surgery is a major procedure, there are complications associated with it. That's how you can explain to the patient if she requests a hysterectomy. Now, they have indications for a hysterectomy in endometrial hyperplasia without atypia. So hysterectomy is indicated in women not to want to preserve their fertility when progression to atypical hyperplasia occurs during follow-up. So that's why you're going to follow them up. 2, there is no histological regression of hyperplasia despite 12 months of treatment. 3, there's relapse of endometrial hyperplasia after completing progesterone treatment. 4, there is persistence of bleeding symptoms. 5, the woman declines to undergo endometrial surveillance or comply with medical treatment. These are your indications for a hysterectomy in endometrial hyperplasia without atypia. You have to memorize and know them because they can be in a counseling station or they can be in a structured discussion. The examiner can clearly ask you that, let's say it's a case of endometrial hyperplasia without atypia, when are you going to consider a hysterectomy for her? Okay, we're going to have 2 examples for endometrial hyperplasia without atypia. The first one that we just discussed, which is the counseling station, and then we're going to do the same exact one but as a structured discussion. So you can just, know the difference of how you would lay out your answer to a patient, how much information you're going to give her, how much detail, and how much information you're going to discuss in a structured discussion to the examiner, because there is a difference. Okay. Postmenopausal women requiring surgical management for endometrial hyperplasia without atypia should be offered bilateral salpingo-oophorectomy together with total hysterectomy. So that's in case if patient later comes in, let's say this exact same patient, we've treated her, at some point she relapsed or she don't respond to the treatment, then when you talk to her about the hysterectomy, you will offer. Don't tell her, we're going to take out your uterus and your both ovaries and tube. It's not a must. Okay? The option that you are mainly offering is a hysterectomy plus or minus bilateral salpingo-nephrectomy, and that's when for bilateral salpingo-nephrectomy you will ask the patient, would you like us to remove your ovaries and tubes or not? Okay. For premenopausal women, the decision to remove the ovaries should be individualized. However, bilateral salpingectomy should be considered, as this may reduce the risk of future ovarian malignancy. Now, this would be applicable in a case of a woman who's not menopausal yet, okay, and you would offer her a hysterectomy, but with bilateral salpingectomy, okay, and explain to her the benefit of having a bilateral salpingectomy, which reducing the risk of ovarian malignancy. Okay, but you would offer for her ovaries to be kept behind, just because of postmenopausal symptoms. Okay. A laparoscopic approach to total hysterectomy is preferred to an abdominal approach, as it is associated with shorter hospital stay, less postoperative pain, and quicker recovery. Now, when you talk about the hysterectomy and offer it to her, you're going to mention it's going to be done through keyhole surgery. Okay, unless patient has, for example, let's say multiple previous surgeries, comorbidities that would put her at increased risk of having a laparoscopy done, then a better approach would be an open surgery. So it actually depends on the comorbidities and the risk factors in the patient. Endometrial ablation is not recommended for the treatment of endometrial hyperplasia because complete and persistent endometrial destruction cannot be ensured, and intrauterine adhesion formation may preclude future endometrial histological surveillance. Now, you can use that if the patient asks you, can't I have the lining of my womb burned? Okay, because sometimes they go and read here and there, so they could have picked that up information from somewhere, from a friend or from the internet or from a leaflet they read before, and they ask you. So this bit here, you can use it to tell them why you wouldn't recommend endometrial ablation. Okay. Okay, so that is about endometrial hyperplasia without atypia. Just let me take this away. Okay, this is the case. Before we go on with the case, does anyone have any questions? You can either type it down or click on the hand icon so I can unmute you and see what questions you have. Okay, no questions. Now, I want to volunteer. Who would want to do this case scenario? Questions? Okay. Okay, Chaitra, and I hope, I'm sorry if I pronounced names wrong, Chaitra and Manika. Both of you clicked on the hand and said you can do. So Chaitra clicked on the hand icon first. Chaitra, do you want to do the case or be the patient? You can unmute your mic. I unmuted it from my side, so you have control now.
Hello.
Yes, hi.
Hi, Vifama. I would like to be the patient.
Okay, all right, that's fine. Okay, so make sure you ask questions in between when I ask you if you have any questions. Okay, just imagine you're the patient and you've been told about what you have. Just any questions that pop on your mind. Okay. Good. So keep your mic unmuted. Let me see. Can you talk? Let me see if I can hear you. Hello?
Hello. Am I audible? Oh.
Yes, I can hear you. Yeah.
Yeah, sure.
Okay, can you talk again because your voice was interrupted?
Yeah, am I clear now?
Yes, yes, I can hear you. Okay, all right. Now, and someone said they want to do the task, so you can be the patient. And you mind? You want to do the task, so I'll unmute you as well. Okay, great. So that means I'll have time to concentrate on the marking. Great. And you mind? Can you hear me?
Yes, ma'am, I can hear you.
All right. Okay. So Anjuman, you're going to be the candidate. Chaitra, you're going to be the patient. Okay. We agree?
Ma'am, I am the patient or
Yes, yes, ma'am.
I'm doing the task.
You're doing the task,
Okay.
and Chaitra is the patient. Okay. Let me open your 10. Do you want 2 minutes to read the task, or you want to start?
Okay, ma'am, I want 2 minutes.
Okay. So I'll give you your 2 minutes, and then we'll start. Okay. You can start reading now.
Okay, ma'am. Hello, I am Anjuman, one of the doctor in the gynecology clinic today. May I know your name and age, please?
I'm Chaitra, 50 years. Sorry, I'm
Okay.
Rebecca, 50 years.
How may I call you as Rebecca?
Yeah, sure.
Okay. Rebecca, I have gone through your notes and it says that you are having problems in periods and you have also undergone some procedures. You are here to discuss about your report. Am I right?
Yes, doctor, I'm really anxious about it.
Okay. Uh, I can understand. Can I ask few more questions and later on examine you, and after that can I discuss about the report? It will help our discussion. How it is. Is it okay for you?
Okay.
Okay, Rebecca, can you tell me about your concern so far?
Doctor, I used to have a bit of bleeding here and there, which
Okay.
was not coming regularly, and sometimes it was really heavy and painful, for which I visited my GP, and then I was tested for something, and now I'm waiting for the reports.
Yeah, I can see. Can I go through your reports? I mean, previous in treatment records. Hello.
Okay.
Okay, thank
Yeah,
you. I can see that you are having some biopsy from your womb. And yeah, the report are here of your womb lining. How do you do after the test? I mean, are you okay now?
yeah, doctor, I'm doing okay.
Okay. Do you have any weakness or vertigo or anything, as you are saying it is heavy bleeding?
Now, initially I used to have, now doctors have given me some tablets. I'm feeling better.
Okay, that's good. Is there any, I mean, mm, I mean, uh, problem in your water work or bowel movement?
No, doctor, I'm good.
Okay. Okay. Can I know about your periods? Has it been stopped? Or I am again started again. Hello.
It comes very irregularly, once a while, once a while. It's not completely stopped. It's not
Okay.
completely stopped.
Okay. Yeah. Can I know about your babies?
I have two kids, doctor.
Okay.
Both of them were vaginal deliveries.
Okay. How they are doing? Are they okay? Hello. Hello. Hello.
Anjuma, I'm just
Hello.
pausing the timing. Chaitra, just her mic went off. Just a second. Yeah. Okay. Chaitra, you can unmute your mic now. You just got disconnected for a while.
Hello.
We are back.
Okay,
Okay.
yes. You can resume. Yeah.
Okay. Do you have any medical condition like high blood pressure or sugar, anything?
Taking tablets for my high blood pressure from past 2 years.
Okay. Any surgery in your tummy or down below?
No,
Okay. Are you up to date with your cervical smear?
yes, doctor, normal.
Okay. Do you have any family history of cancer or blood clots in legs and lungs? Hello?
Chaitra, can you hear the question?
Hello? Hello?
Hello, Chaitra, can you hear us? Okay, Chaitra went offline. That's fine. Anjuman, I've paused your timing. I think Chaitra, you're having a problem with your connection. Manikam, I'll unmute you. You said that you wanted to um, be a patient as well earlier. Can you unmute your mic? Manikam, you have a mic icon. You can click on it. Okay, that's fine. Manikam is not there. Chaitra is back. I'm sorry. Chaitra, can you unmute your mic?
I'm really sorry for that, ma'am, but I'm
That's
back.
fine.
I'm back. Sorry.
That's fine. I paused the timing. Okay, you can resume.
Ma'am, should I continue or the task is over?
No, continue, continue.
Okay. Do you have any family history of blood clots, in legs and lungs or cancer?
No, no, doctor, no.
Okay. Can I ask you personal questions like your smoking habits or any alcohol habits if you have?
I do smoke almost 5 to 6 cigarettes per day. Otherwise, nothing else, doctor.
Okay. I know smoking is something that we don't recommend. Actually, it is harmful for health. But if you try to quit it down, it will be good for you. You can think about it. What is your opinion?
Okay, let me
Okay,
think about it, doctor.
thank
Let me think.
you. Okay. But do you have any allergy?
No.
Okay. Are you aware about your weight height ratio? Hello? Hello?
Um, okay, it's 40.
Yeah, I can see it's quite higher side. It is higher weight height ratio is not also things. I mean, may have some impact of one's life. We have our obesity management clinic, dietitian, nutritionist. They can help you to make it lower. How it sounds to you?
Okay.
Okay. Thank you, Rebecca, for your information. Now, I have matched the name and NHS number of the report, and there are one scan report of your womb, and there is also a tissue report. Your scan report says that your womb lining is increased in thickness, and your tissue report says that your and there is a thickness that I like increased thickness of womb lining, but there is no other cells, I mean abnormal cells. Uh, am I clear so far, Rebecca? Hello?
Yeah,
Hello?
I'm with you. I'm with you, doctor.
Okay. In
Yeah,
one,
I'm with you.
okay. The things is that the thickness increase in womb lining has some implication in life, that as you have experienced the bleeding, sometimes it becomes very, it may affect the quality of life. And in some in some instance, like if there is 0.5% chance of this womb lining increased thickness of womb lining may turn into a malignancy. So it is necessary, if it is important to treat. Am I clear, Rebecca?
Doctor, what do you mean by this? Do I have cancer? Do you mean I
No,
have cancer, doctor?
at this point you have no, the report, according to the report, there is no such abnormal cells that but the thickness is increased, but which is in the long run, I mean over the 20 years, there is some few percentage chance that it may turn into cancer. That's why it is necessary, it is if necessary to treat. Am I clear,
Mhm.
Rebecca? We are here to help you. We have our consultant will be treatment put on treatment under consultant, also a specialist nurse, and there will be the and a group of doctors who will help you to in this case.
Mhm.
Is it okay, Rebecca?
Okay.
Hello.
What can I do about this, doctor? How should we go about this now? I'm really
Okay.
worried about the report.
Yeah, I can understand it, but we are here to help you. As there are several options so that the thickness can be reduced. There are some medical options, and also there are some operative options. Among the medical options, we can put you a coil inside your womb, okay, and it will decrease the thickness of the lining and make it normal over the it. We will observe you over 12 months. We will follow up you 6 to 12 monthly, okay, with the
Mhm.
again the process. And if it goes back to normal, okay, it is okay. Otherwise, if it does not work, and if you opt for surgical options, the other option is we can surgery, what you say, we will remove your womb, so that the we will remove your womb. This is one of the solution. Do you have any
Doctor,
preference?
do you mean I'll be all right in 6 months? I don't have to need any further treatment after 6 to 1 month.
We will again check you after the medication, that what we call it LNG IUS, that is a coil will you put
Mm-hmm.
you inside your womb. And after 3 to 6
Mm-hmm.
monthly we will check you by a scan, and also take some tissues as you have gone through the, and tissues will be put on the lab and see whether thickness has gone away or not. Okay, if it is gone away, it's okay, but if it is not gone away, then you need to continue the treatment for another 6 months. Am I clear?
Mm-hmm. Okay.
Okay, okay. So some women may that does not want to do this, or sometimes if the recurrence happen again, or if the over the period of time, if the I mean tissue report shows there is something abnormal. Okay, in that case, surgical option, that is removal of the womb, is we preferred. Am I clear, Rebecca?
Okay. Okay.
Okay, and when the decision, is there any specific, I mean, yeah, after the removal of the womb, is there any opinion of your, I mean, any regarding your egg basket? I mean,
No.
in some women prefer to remove it, or some women not.
No, I don't want to remove my womb, doctor.
Okay, in that case, we will respect your opinion, and let me inform you, there is a 1% chance there may be a problem in after the operation. There's like over there may be some cyst in the ovary, or
No, no.
there is.
I don't want. I don't want the
Okay,
surgery, doctor. Please give me the other option.
okay. In that, okay, I respect your opinion. In that case, I am giving. In that case, as I have said, I can give you the coil inside your tummy. Okay, at the same time I need to do
Mm.
some blood test to see your blood level, whether you need to blood to check the hemoglobin if you have any other diseases, like sometimes diabetes, high blood pressure, or the high blood sugar, or okay, and if it is any of this present, we will also optimize that as well. How it is it okay, Rebecca?
Okay. Doctor, I'm seeing my GP for 2 years with the blood pressure. She always told it is good, under control, and my report is showing some fibroid. So what to do about that, doctor?
Yeah, but yeah, there is also tumor 3 into 3 centimeter, but it will also sometimes goes away with the copper coil also. I mean, what we say it, I mean, I'm sorry, the hormone coil. Okay, sometimes the hormone coil that are going to be placed inside your womb, sometimes they also the size of the fibroid also decrease. Am I clear? And as this is an
Okay,
outside the
that's
womb lining, it is the womb lining, and it may not be responsible for your bleeding.
mm-hmm. Okay.
Okay,
Yeah.
okay, but do you have any more question?
No, no, doctor.
Okay, there is a lot of information. I am giving you patient information leaflet, and also book an appointment with my consultant, and introduce you support groups. Is it okay for you?
Yeah, doctor. Thank you.
Thank you.
Okay, thank you so much, Kaitha. You asked really nice questions. Thank you for that.
Okay.
Um, Anjuman, how did it go?
Hello, ma'am.
Yes. How do you feel you did?
Ma'am, I'm little haphazard, confused. Suddenly,
Did
I have to give that test.
or did you take the exam before?
Hello.
Did you take the exam before? Or is it your first time?
Yeah, I have appeared in November.
Okay. All right. This November.
Yes, ma'am.
All right. Okay. All right. Thank you so much, Anjuman. I'll mute you for now. Okay. And I'll give you the feedback and then tell you what things you need to work on. Okay. All right, so let's start with your communication with the patient, and then I'll ask after that Chaita about how she felt as a patient, okay? Because patient feedback is very important as well. Now, your communication, you had a really nice start. So you introduced yourself and role, you confirmed the aim of the consultation, that why the patient is here. You elicited if she has any concerns. You explained that, so you related the scan with the histopathology report. So on the scan, you mentioned that the lining was thickened, and then you explained the histopathology report. You were inviting questions. You were using layman terminology. Only issues I had with this is that you use the word I understand. Usually they say I can see, or it's understandable if a patient is worried. Because if you say I understand, patient can tell you, well, how do you understand? You don't have this. Did you have this before? Okay, and then you will be there squeezed in a tight corner. So usually choose say for all of you as well, it's understandable or I can see. Okay. Now, the reason why I gave you a borderline and Germanic communication is that you were hesitant in between in the management. Okay, you need to have this continuous flow, all right, and not pause in between, and that displays confidence, and that's part of communication with patients. Communication with patients marking doesn't have any relation with the information, is it right or wrong? It's the way you give the information, the continuous flow, you being confident. Okay, now I gave you additional time. Your time did end, although you did really good. Okay, the amount of information you covered in those 10 minutes was enough, but I gave you additional time and you didn't conclude at the end. So you talked to the patient about the marine and everything, and Chaita was telling you that, okay, I don't want a hysterectomy. She asked you about the fibroid and everything. You answered all of that. At the end, you tell her, okay, any questions? She said no, and you ended it. Come up with a conclusion about, okay, what's going to be done next? Does she agree for the Marina coil or not? If yes, you can fit it in. Okay, you can fit in that coil, or if she wants to think about it, give her some time for the coil and then to come back, and then the coil can be fitted once she makes up her mind. All right, so always, if you have time at the end, always reach a conclusion, which is an important part. It's a summary at the end regarding all what you've talked about. What is the outcome of this consultation? Is the patient going to have the coil or not? Does she agree? Yes. Does she disagree? Okay. If she disagrees, what does she want? Does she want to think about it? Okay, give her time to think about it. Okay. Now let's come to all information gathering. Now you did really good here. The way you asked the questions was really nice. You were systematic. You started with an open question. So always it's advised to have an open-ended question regarding their complaint, not a closed-ended question. So an open-ended question is a question in which the patient gives you an answer, not yes or no, but she gives you a sentence. Okay, she describes. I really like the fact you asked her about her recovery after the procedure. You inquired about symptoms of anemia. Well done. You did use the word anything twice. That is very vague. Try not to use anything. Okay. If you want to ask medical history, you can ask her any chronic long-term health issues that you have. If they're diabetic or hypertensive, they would tell you. Okay. But don't say, do you have any diabetes or hypertension or anything? Okay, avoid the word anything. I really like the fact that you inquired if she is still symptomatic, because that would determine your treatment. Maybe the heavy bleeding was because of the polyp and now it's gone. Now she's not symptomatic, and the hyperplasia is not the reason for her bleeding. So you can offer her, controlling her BMI or controlling any risk factors in any other patient, and observation as well. But since she's still bleeding, it's good that medical treatment applies for her. Okay. You then, for your question on parities, you ask, can I know about your babies? Now, you don't know if she's delivered before. I didn't give you her parity. Okay, so when you ask about the parity, did you ever get pregnant before? Okay, that's it. I mean, since she is, and you want to know the mode of delivery as well, because later on she may need a hysterectomy. You want to know if she had any previous multiple cesarean sections. That is the only that's the only indication for why you would want to ask such a question in her age. If she was still in the reproductive age and you're querying whether she wants her fertility, she's trying for another baby, she wants a baby, then that would be very relevant. Okay, asking her about her parity and her future fertility plans, because that would depend, that would help you talk about the duration of the Mirena coil being in and when she can try for a pregnancy. Okay, you then went to the rest of the history: smear, medical, surgical, family history of cancer, well done, social habits, and drug allergy. Okay, where you finished from the history, you had 4 minutes and 40 seconds left. That is quite enough. I mean, I would prefer if you had 6 minutes. That would be ideal, because for history, it's recommended for you to have 3 minutes maximum spent on the history. I do appreciate as well, because it's online, there was interruption, but I did pause the timing when Chaitra went online. There was offline, there was a problem with her connection. I did pause the timing, but then again, it's not like face-to-face. Face-to-face, you ask the question, the patient answers right away. But in an online practice, there can be that delay just due to the internet. They're answering you back. It's not as quick as if it's face-to-face. All right. So any of you, if when you're practicing, whether in a course or with your study partner, time yourself during history. If you find you're taking more than 3 minutes, work on that to try to fit it into 3 minutes, because you still, those 3 minutes there, you're purely marked on your information gathering. If you spend lots of time on information gathering, then you're going to jeopardize your marking and applied clinical knowledge, safety, and colleagues, which would be marked after your history taking, when you're counseling patients regarding management. All right. Sorry to interrupt. If my voice becomes unclear at any point, just someone let me know. All right. Okay, so you have 4 minutes and 40 seconds. Then during the history, you gave smoking advice. Okay, well done. And you gave advice for BMI. But then again, and I gave you the markings for that because you did mention them. But I mean, you just told her stop smoking and reduce her BMI. It's highly unlikely that Taitha is going to think about doing that or taking it very seriously, because you just mentioned it like that. You didn't relate it to her condition. So that's why, for it to make sense to the patient, when in the exam, when you're taking history, you have a note. They give you a notebook and a pencil. You use it in the 2 minutes and you use it inside as well. You can ask the patient before taking history, would it be okay if I write down some points as we speak? She says, yes, I did that in my exam. So when you pick that she's a smoker, write down smoking. If high BMI, write high BMI. Okay, write these points down when you're taking history so you can cover them. It will make much more sense if you cover it during your management plan and relate it to helping her in the management of endometrial hyperplasia. That's when the patient will take it seriously, because it's part of managing her condition. Okay. Now let's come to, sorry, let me just do my screen. Let's come to patient safety. From when you confirm that that's the correct patient you're seeing in front of you, I gave you a mark. When you gave smoking advice, I gave you a mark. When you talk, the most important point that I was looking for, if you didn't mention it, I would giving you a fail in patient safety, which is risk of progression to cancer, which is 5% over 20 years. So well done, you mentioned that. So you were quite safe, okay, when managing her. Also, you inquired about any drug allergies. Sometimes, because you are going to offer a Mirena, it would be a good practice point to just inquire about any history of STIs or current vaginal discharge. Because if she says, yes, I want the Mirena coil, you can insert it right away in the clinic, okay? And if she does have abnormal vaginal discharge, tell her, okay, we'll take a biopsy for the discharge, make sure you don't have any infection, and then when the result is out, then we can fit in the coil. There's no urgency. It's not emergency contraception for you to have to insert it now, right away. Okay, so again, you know that a Mirena coil is and a copper coil as well is an option, but mainly the Mirena coil is an option for not just contraceptive purposes, but for other gynecological problems, and you can find it as an option in many cases. So you have to remember just to make sure that when you insert the coil, you're being safe by just excluding any possibility of an infection down there that needs to be cleared or investigated before inserting a coil. Okay. Let's come to communication with colleagues first before knowledge. So communication with colleagues, good, you talked about the obesity clinic, but usually we give them advice regarding, healthy diet and exercise, and through your GP, we can refer you to a dietitian. So your GP is the point of contact for any referrals required. All right. Now, applied clinical knowledge. So Anjuman, here, you talked about a Mirena coil, and then you mentioned 6 monthly biopsies, and right away you went and talked about a hysterectomy. You weren't really, you didn't elaborate on the Mirena coil, because that's the most important first line management option. Chaitra, as a patient, has the right to know all the information about the Mirena coil, how long it's going to stay, how often will be the biopsies, when you're going to discharge her. After you finish from that part, then you go and talk about, ask her if she agrees on it or not. If she says yes, that's fine. If she says no, I don't want the coil, is there anything else? Then you talk about oral progesterone. Okay. Hysterectomy, leave it until the end. Say, if, like, for example, you're not responding to the coil, or during the follow-up when taking the biopsies, another form of abnormal cells appear, then we would go ahead with, we would offer you. Okay, you always mention, don't say we have to do or need to do. It's usually offering patients, because it's not a must, they can decline. Okay, so offering. So here I gave you Phil because you talked too much about a hysterectomy and you didn't elaborate on the Mirena coil, and check if she wants the Mirena coil or not, just to see if you would need to talk about the oral progesterone. Okay. Chaitra also asked you about the fibroid. So well done, you answered her correctly. That it's a benign growth on the top of the lining of the womb. It's quite small. It's not having any effects, and it's not causing the abnormal bleeding. And we usually don't do anything regarding that. Okay. So if I was to do this patient, okay, and Anjuman, all of you just listen to me. So Anjuman, here, I'm going to change a few things in the order of which you ask those 2 open-ended questions regarding her complaint and regarding the recovery from the procedure. You ask them in the history, but what I'm going to do, I'm going to mention them at the beginning before the history, just to involve the patient with me at the beginning. Hello, my name is Wafa. I'm one of the doctors in clinic today. Can I confirm your name and age, please? I'm Rebecca Clark. I'm 50 years old. Is it okay if I call you Rebecca? Yes, that's fine. Please call me Wafa. So Rebecca, how are you doing this morning? It's nice to meet you. Yes, I'm doing fine. Nice to meet you too. I'm seeing you for the first time. I've gone through your notes as well. I understand you had a procedure 3 weeks ago and you're expecting to discuss the results today. Am I right? She will tell you yes. So before we go ahead to discuss the results, in your own words, can you tell me what you understand about about your condition until now? So that's about her complaint. She's going to tell me, I had the bleeding, then I had the scan, and then I had the procedure and everything. How's your recovery from the procedure? Any problems at all? No. Is the bleeding still there? Just want to know if she's still symptomatic. As we know that, okay. So can I ask you just a few questions, and then we'll go ahead with explaining the results and then discuss with you the management plan. At the end, I'm going to give you a leaflet and write back to your GP. How does that sound? She'll say yes. So all of that, I did it in the introduction part, just to create a report with her, okay, and check that we're on the same page moving forward. And then I gave her an outline of what we're going to discuss. I included a leaflet and writing back to the GP, because if you leave it until the end, you cannot guarantee that you would run out of time or not. Okay, and these are like small, easy, simple marks that you can collect. Now, when we come to the history, okay, since I've already asked the open-ended questions at the beginning, it's okay for me to start the history as normal. Okay, I'm going to start the history by inquiring about, so I can start by confirming a few points about the bleeding. So I can tell us, okay, If she says yes, you can take the history. Is it okay if I write down some points as we speak? She will say yes, and then I start asking her. So my first question would be, you can start with any question, but I will start with the presenting complaint as well about the bleeding. So I'll just confirm or recap what she told me. So okay, so Rebecca, as far as I know till now, you had the heavy bleeding, and even now after the procedure, you're still continuing to bleed. Is that right? She'll say yes. Do you feel any dizziness, any fainting episodes, or running out of breath? So I'm asking her for symptoms of anemia. Any issues with your bowels or going to pee? No. How about your smear test? So I start with the gynae history. I'm going to finish with the gynae history. How about your smear tests? You want to know if they're up to date and they've been normal or not. And then I'll go to her sexual history. Are you sexually active? Yes. Are you using any contraception at the moment? No, I don't think so, because I don't think I'm going to get pregnant. Okay. Do you have any abnormal vaginal discharge? No. So that question is relevant because I am going to offer her a Mirena coil. I don't want to be safe when offering it to her. So basically, when you're taking history, think about each question. Is it relevant to my management plan or not? It has to be relevant. You're not just asking random questions. Okay. And then so like, did you ever get pregnant before? Yes. Few quick more questions. Any health issues? Nope. Any surgical procedures apart from the hysteroscopy that you had a few weeks ago? Nope. Any family history of cancer? Nope. Do you smoke? Do you drink alcohol? Any recreational drugs? Are you allergic to any medication? Okay. Now, by the time you reach this point, ideally you would want 6 minutes, but if it's not possible, 5. So 5 to 6 minutes to be left remaining for you to explain the results and talk about the management plan. So when you come to after the history, I thank you for sharing this information with me. Anything else you would like to add? No. So coming to your results, so you know that when you had the scan 3 months ago, it showed that the lining of your womb was thickened, and they queried if there was a polyp. When you had the procedure, the polyp was removed, and a sample from the lining of the womb was taken just because it was thick. Now it was looked at under the microscope in the lab. What they found that you had overgrowth of the cells of the lining of the womb, but the cells are not abnormal and they're not cancerous. Okay, does that make sense to you? She tells you yes, tell her. Okay, so because of that, and you're still bleeding even after the polyp was removed, that thickened lining of the womb is responsible for why you're having the heavy bleeding. So that will take me now to your management plan, and we do have options for you. At any point, if you want to ask me any questions, feel free to do so. So after you explain the result, make sure she understands the diagnosis, and then you go to your management plan. Now here in your management plan, what you want to do is talk to her about the risk of progression to cancer and make it clear. So the patient doesn't ask you, do I have cancer at the moment? And then you talk about controlling risk factors, which is the smoking and reducing the BMI, and then you talk about the hormonal management. Okay, it just has to be quick, 1, 2, 3, 4, without pausing in between. So when you come to the management plan, where you can tell her that with this with this overgrowth of the cells inside your womb, there is a chance that you can say that there is a 5% chance that it may progress to cancer over 20 years. That's why we recommend treating it. So the first thing is controlling the risk factors or the reasons for why this may have happened. The first one is smoking. So we would recommend stopping smoking. We do have our NHS Stop Smoking services. I can give you a leaflet regarding that after we finish. I wouldn't ask her, do you want to stop smoking? Because at that time, she'll tell me no, or I want to think about it. I just give her the leaflet. We just need to give advice, give them a leaflet, and then they'll decide. Okay, so the second point is your BMI. So your weight is on the higher side. We would recommend you reduce your BMI ideally below 30. To help you with that, through your GP, you can be referred to a dietitian for a healthy diet and exercise program. Okay, so now in terms of a medical management, we usually advise a Mirena coil. Have you heard about a Mirena coil before? So you can ask. So that's a way of involving patients, because a lot of them know what a Mirena coil is. You can tell you, well, yes, I've heard about it. It's a contraceptive. She can tell you no. So tell her it's a T-shaped device that inserted vaginally through your cervix and it stays inside your womb. Okay. It's surrounded by a sleeve of a hormone that thins out the lining of your womb. And by that way, we can control the overgrowth of the cells and the cells will return back to, their normal growth or level. When it's inserted, there's a risk of infection. Sometimes it can not be positioned properly. You can have abnormal bleeding or spotting for the first 3 months until your body gets used to it. We would recommend that we bring you in for a sample to be taken in the clinic from the lining of your womb every 6 months. Once you have 2 negative samples, which are 2 normal samples, then we do it once every year. Why am I saying that once every year? Because she has a high BMI over 35. If her BMI was normal, then it would be different. I'll tell her that once we fit it in, every 6 months, we'll bring you to clinic, take a sample from the lining of your womb. Once we have 2 negative samples, then we can discharge you from clinic and you can follow up with your GP. And we recommend for it to be stayed in there for 5 years. Okay? So in summary, what I did or what you're supposed to do is explain to her the option, which is the Mirena coil, how it's going to help her. So I did tell her it thins out the lining of your womb and controls the growth of the cells, and the cells will become back or return back to their normal level or density. Okay, and for how long or how the follow-up would be and what she would expect in terms of the treatment. Okay, and then ask her, do you have any questions? Are you okay with the copper core with this option? Make sure if she tells you, is there anything else apart from the coil, because I'm not really comfortable with it, in that case tell her yes. So for women who decline the Mirena coil, which is the best in terms of treating this condition, we have the same hormone in the coil, but it's taken as tablets. Okay, take it continuously throughout the month with no breaks at all. And then we would follow you up in the same way as the Mirena coil, but you have to bear in mind that it is less effective than the Mirena coil. Okay, so here I'm not mentioning anything at all about the hysterectomy till now because there's no indication. If I do have some time after that, tell her that during the follow-up there are certain things we would want to look for and for you to keep an eye on. If you're bleeding after it gets better, it starts to come back again, it becomes worse, you need to let us know. If at any point when we're taking the samples in the clinic, we find that the cells have become abnormal in terms of how they look like, then in that case, we would discuss with you the option of a hysterectomy. Okay, you don't need to talk about hysterectomy, it would be laparoscopic, and then you want to remove your ovaries or not and everything. It's not the time for it. Unless there's a contraindication for the hormonal treatment, and that's the only option, or the patient refuses all of that and she demands for a hysterectomy. Okay, after I finish, I ask her, so you can see that the amount of information that you will mention actually depends on the patient. That's why it's very important to let the patient interact, to give her that space to ask questions to see if she agrees with that option or not. If the guideline did mention that the patient can be offered a Mirena coil and oral progesterone equally, then you will change the way you're going to mention it. You're going to tell her we have 2 options. One is the Mirena coil, talk about it. The second one is taking it in the form of tablets. Okay? And ask her which one she prefers. That's if the guideline says it, you can mention both equally. But the guideline mentioned Mirena coil, number 1. If they refuse, then progesterone. So you cover the Mirena coil first. Don't give it as options. Mirena coil first. Ask her if she agrees or not. If she says no, then you go and cover the oral progesterone. Okay. Because the reason why I usually try to focus on these things is that you can have really good candidates who have really good knowledge, but their only problem is that they do not listen to the patient, and they just give option. Okay, they've read the guideline, they know that the mean their progesterone was hysterectomy, and they try to mention everything in those 10 minutes to the patient. Yes, you covered the knowledge for the part 2. That would be ideal if you're writing an essay or answering questions, but you're not tailoring it specifically to that patient in front of you, to that patient who's 50 years old, who doesn't desire fertility, who her BMI is 40, who you don't know if she agrees for the coil or not. Okay? So you need to put all of these factors into consideration when treating patients. So that's why part of applied clinical knowledge, I always say, is that it's just not your knowledge from the guideline, but it's your knowledge regarding what can I say? It's the applied clinical knowledge tailored specifically for that patient in front of you. Because patient A, who has endometrial hyperplasia without atypia, her treatment options that you will tell her would be completely different from patient B, who also has endometrial hyperplasia without atypia. But their age is different, their BMI is different, their fertility plans are different, and also their views are different regarding whether they want to have hormonal treatment or not, and also if they're willing to come in for follow-up or not. Okay. Sorry, I know I've taken a lot of time. We started 3 and now it's almost 5. It's 2 hours just on one station. But, you know, it's not just about endometrial hyperplasia with atypia. It's about, in general, the way you think when preparing cases, when doing cases in the part 3. Okay. Someone asked on the Telegram group, shall we suggest bariatric surgery for this patient, BMI 40 months? Usually bariatric surgery under the NHS, they're not qualified for it to be done under the NHS unless they've tried losing weight before. They've tried with a dietitian, with a physiotherapist, they tried everything, but they couldn't lose the weight. That's only then when they can have it under NHS. Apart from that, they have to go private and pay for it. And it's the patient choice. If she tells you, I tried dieting and exercising, it's not working, I can't do it anymore, that's when you can tell them, okay, you can explore with your GP options of surgery, okay, like gastric sleeve, or any medications that would help you. Okay. Anjuman, do you have any question? Anjuman, you can unmute yourself. Your mic is still muted. Nope. Okay. Anyone has any question? Now, this is a structured discussion on endometrial. I'm not supposed to tell it endometrial hyperplasia without atypia because it's kind of a gradual thing in terms of assessing her, and then later on I give you the findings to know. But I mean, all of you know now. It's just for teaching purposes. But it's in a structured discussion just to show you. I mean, the initial part of the discussion that's going to start with your differential diagnosis, your assessment. It's not because you have the assessment already in that previous case scenario that we did, so you don't compare that to the previous case. But what you're going to compare is the way you're going to answer. Okay, once you have the diagnosis. Okay, you're most welcome, Anjuman. Thank you. Who wants to volunteer and do it? All of you have the knowledge, so it's different from a counseling station. It's just purely knowledge. We're just going to convert what we did in the previous case and convert it to a structured discussion. Okay, so what I can do, instead of giving this case to one person, now, each person is going to have a question. Okay, let's read the scenario. Structured discussion task, assessing information gathering, communication with colleagues, patient safety, and applied clinical knowledge. I've omitted communication with the patients because it's not required. I don't want that to be assessed here. Okay. Now, you are the ST5 and you're about to meet the examiner who will play the role of your consultant and discuss with you the following case referred by the GP. Now, this is the GP letter. Dear colleague, thank you for reviewing this 60-year-old lady who has been menopausal since the age of 52. She presented to me complaining of vaginal bleeding for the past 11 months. Okay, it started with spotting for 4 months, then increased in amount to be as of a normal period. I have started her on ferrous sulfate tablets, 200 milligram twice a day. She's non-diabetic for the past 10 years and is on on metformin tablets. On abdominal examination, I could not feel any abnormalities. Her periods prior to menopause were regular. She is a para 4, all by normal vaginal deliveries. Yours sincerely. You have 10 minutes in which you will discuss the possible causes, assessment, and management of a patient with the examiner, who has 5 questions to guide the discussion. Now, I want one person to answer the first question. The first question is, what are the possible causes you can think of vaginal bleeding? So it's a case of post-menopausal bleeding. Who wants to answer this question? Just the first question. Don't worry, I'm not going to make you do the whole case scenario. Come on, all of you know postmenopausal bleeding. What are the reasons for postmenopausal bleeding? Anyone, you can click on the hand icon so I can unmute you. Anyone? Okay, Chaitra, I'm going to choose you. Can you unmute your mic? Just give me any reasons you can think of.
Okay, ma'am, I'll try.
Yeah.
So I'm supposed to do information gathering, ma'am.
No, I just want differential diagnosis.
Okay, okay. Ma'am, since it's the 60-year postmenopausal bleeding, first thing we would like to think of is atrophic endometritis. Next is endometrial hyperplasia, endometrial polyps, or it could be a cervical lesion, or it could be a fibroid, or any other local pathologies.
Okay, elaborate more. What cervical lesions can it be?
It can be most cervical growth, or at this stage, it's usually either a cervical polyp or a cervical carcinoma.
Okay, so endometrium, you mentioned in atrophic endometritis, endometrial hyperplasia, endometrial polyp. What other, and fibroid, what other endometrial pathology? The most important thing you want to
Yeah,
exclude.
endometrial carcinoma. Endometrial carcinoma, definitely.
Okay, going down to the vagina, what can be the reason?
Yeah, atrophic vaginitis, then sexually shared infections less likely at this stage.
Okay, anything, so these are all local reasons. Anything else generalized that can cause bleeding?
Yeah, yeah. If she is a known case of cardiac disease on aspirin or any clopidogrel, any medications are blood thinners basically,
Yeah.
which has been recently started,
Yeah.
warfarin, she can have such type of postmenopausal bleeding. So general medical illness to be kept in mind. Then what else?
Any other medication she can be taking at her age that can cause bleeding? She's 60. What can she be taking that can cause
HRT.
irregular?
I mean, here, yeah.
Yeah.
She may be taking HRT for some symptoms of menopausal transition symptoms,
Okay.
hormone replacement therapy like estrogen, progesterone.
All right. And can it also be bleeding from elsewhere apart the vagina?
Mm,
Where can she be bleeding from?
like other than vagina and cervix, it's like slightly like
Like other from
hematuria. Like hematuria, she may be having
and?
bleeding from and bleeding from anus. So we have
Yeah.
to keep those two things in mind. Yes.
Okay. All right. Thank you so much, Chaitra. I'll just mute you for the time being. So well done. So let's go through your answer. So you said there's a case. So usually when you have a case like this and they ask you possible causes, you kind of assume that you're going to go through history. So in the exam structure discussion, the crucial mistake that you can do is answer beyond the question. Always read the question carefully. If they ask you for your differential diagnosis or causes or complications, anything like that, it's not about information gathering. They just want to know the differential diagnosis or the reasons or the complications. You just list them down. And when you're listing, especially causes or differential diagnosis, you start with the commonest and then tailor it down to the least commonest. They mark you on that as well. Also being systematic in your answer. So for example, if Chaitra has said, started with like atrophic endometritis, endometrial hyperplasia, it can be medication she's taking, then she goes back, endometrial cancer, endometrial polyp. She's not being systematic. The examiner can mark you down on that as well in terms of communicating with them. That's communication with colleagues. Okay, so again, I repeat, having a systematic answer starting with the commonest to the least commonest. Again, if they ask you, if you have a pregnant lady and they ask you regarding, let's say she has a high BMI and she's pregnant, asking you about what complications or what are the risks that can happen. So if it's a general question regarding risks or complication, divide it, categorize. Say, high obesity with pregnancy has its antenatal, intrapartum, and postnatal complications. Antenatally, there's maternal and fetal. So maternal antenatal complications can be 1, 2, 3, 4. Fetal antenatal complications 1, 2, 3, 4. Going ahead with intrapartum complications 1, 2, 3, 4. Postpartum complications like wound infection, delayed wound healing, DVT, and all of that. Okay, that's how you categorize, and you apply this to any case scenario that has a question like that. So Chaitra started with the endometrium, so he said atrophic. So she didn't start with endometrial cancer right away, although it's the most important thing that you want to exclude here. But then there are other common causes like atrophic endometritis, endometrial hyperplasia, endometrial polyp, and you can say most importantly that I would like to exclude is endometrial cancer. Going ahead to the cervix, it can be any cervical lesion such as CIN, cervical polyp, cervical cancer. Going ahead to the vagina, most common is atrophic vaginitis. It can be a foreign body or an infection, although I highly doubt that can be the reason, just given the period and the amount of the bleeding. So you're kind of, showing your knowledge to the examiner. General reasons can be medication that she's taking, if she's on any blood thinning medication that's been recently started, if she has chronic medical problems, if she's on HRT that she's not compliant with or it's newly started. She may not be bleeding vaginally, it may be rectal bleeding, and also it may be hematuria, although it's less likely because she has to put a pad on and the bleeding is continuous. So again, it can be rectal bleeding. So we left the general medical problems and, rectal bleeding and possibly hematuria as well towards the end, because it's not the thing that you'll be thinking about at the first instance. Also, you having a differential diagnosis in mind will help you in terms of your history. So each reason that you mentioned, you have to inquire about it in the history. So for example, you talked about vaginal atrophic vaginitis. That would be relevant when you ask about sexual history. Any vaginal dryness, any postcoital bleeding. Cervical causes any postcoital bleeding as well. And what is it as well? Any abnormal smear, so inquiring about the smear history. You talked about STI as a possible reason, so any abnormal vaginal discharge or previous STIs. Okay, so that's how you go about it. And one of your differentials was endometrial cancer and cervical cancer. So also you would want to exclude any symptoms of cancer like weight loss, loss of appetite, change in bowel, urinary habits, family history of cancer. Okay, that's how you use your differential diagnosis in terms of assessment. Okay. Now, my second question would be, and that's a continuation to the answer of the first question, what information in the history and examination would you like to know? So here you're just going to imagine that this patient, you're in gynae clinic, patient came in, referred by the GP, you read the letter, you now know it's a case of postmenopausal bleeding. Now, what are you going to ask in the history and what are examination you're going to do during that consultation? Now here, when you have a structured discussion, your questions have to be systematic, and also don't say, I will ask the patient this, I will ask her about that, and use layman terminology. That's not the way you answer. For example, if I started off, I can say that history and examination is very crucial as to determine or have an idea regarding the differential diagnosis for her postmenopausal bleeding. So in terms of history, I would like to start with the bleeding itself, in terms of the duration, the intensity, if there's any clots, how many pads she needs to change a day, and then you complete it with the rest of the gynae history. Okay, finish that with the smears, and they say, going further to her sexual history, I would like to know 1, 2, 3, 4, and you use medical jargon, any dyspareunia, any postcoital bleeding, any so and so. Okay, and then you go ahead to past obstetrical history and say what you want. I want to know in terms of a medical history, 1, 2, and 3, and so on. Okay, that's how you lay out your history. When you come to examination, if this was a patient and I want to offer examination, I'll just tell her, is it okay if I have a feel of your tummy and then examine you down below, do a vaginal examination just to have a feel of your womb, and then I'm going to insert a speculum to take a look at your cervix. If I do find any abnormal discharge, I would like to take some swabs. Is that okay? Or do I have your permission? So you're briefly explaining the examination and taking her consent and agreement. Okay. In a structured discussion, it will be different. So what you can say is that I want to do an abdominal examination to feel for 1, 2, 3. I would then want to do a pervaginal examination to feel for, or by manual examination for this, this, and this, and then proceed with a speculum examination for this, this, and this. That's how you mention a structured discussion, and you justify your examination. Some people will say, I want to do an abdominal and then pervaginal speculum examination, and that's it. They wouldn't elaborate. Examiner is not going to give you any marks at all because it's considered an empty answer. What they want to know is that if you're an ST5 registrar in clinic, are you able to completely and correctly assess a patient? Okay, they wouldn't be able to know that if you don't justify what you're looking for in your examination. Now, who wants to answer this question? We want Samah and Manikam, you have your hands clicked, so I don't know if you recently clicked on the hand icon or not. So can you just unclick it so it disappears? And if you want to click it again, click it again. Yep, so who wants to do this part? Just history and examination. Chaitra, if you want to proceed, you can.
I was trying to type. Actually, I don't know where to type this chat. That's why I couldn't communicate with you before. Yeah.
Oh, okay, that's fine.
Yes, ma'am.
Okay,
Yeah.
you can start.
Yes. Um, Ma'am, as we know that lady has a history of bleeding from past 11 months, I would like to continue with the history of bleeding. How many pads she's changing? Is she taking any medications to control the bleeding? And is she feeling tired because of that? Or what treatment has been started on this? And is there any history of foul smelling discharge associated with the blood stain discharge which is coming? And is it painful or not painful? Whether it is associated with sexual activity, postcoital bleeding is there or not? Is it associated with dyspareunia? Then, as we thought about the other reasons like endometrial carcinoma, was there any history of loss of appetite? And is there any history of weight loss associated with bladder and bowel symptoms? Which can exclude both endometrial and cervical carcinomas. Then, if she has any recent history of change of medications in case of hormone replacement therapy, which she was not compliant, which was started for her in menopausal symptoms, then is there any history of medical illnesses like cardiac disease, which was diagnosed recently, and blood thinness, which was started? So, after knowing this, I would like to examine her
Okay, I'll stop you. You still have,
physical features like
Chaitra, you
anemia.
still have family history and social history. What would you like to know regarding these two?
Okay, okay. Yeah, sorry. So, ma'am, like she's not including everything. Okay, sorry. So, is there any family history of similar complaints where any family history of gynecological malignancies like breast, womb, and ovary? And is she having any history of clots in the family, running in the family? Then, is there any history of
Chaitra, your voice, it's gone. I lost your voice. Hello? Yes, Chaitra, you can unmute. Yeah.
uh,
Okay, so
yes, ma'am.
Chaitra, you
So
covered
this
family
is about
history.
history.
How about social history? What would you like to do? What would you like to know?
Social history. Are you well supported at family? Whom do you stay with? And
Mhm.
like smoke.
Yeah.
What do you do for living? And
Hmm.
smoking alcohol and drugs, ma'am. These three
Okay.
things.
All right. Now you wanted to go to examination.
Yeah. With your consent, in the presence of chaperone, I
So
would
it's
like
a
to do.
structured. So it's a structured discussion. You're laying your answer to the examiner.
Okay. I would like to do a general, complete, thorough body examination, head-to-toe examination to look for anemia, features of any cachexia like weight loss in the recent, then the features of breast examination to rule out any lumps. Then I would like to come to the gynecological examination. Abdomen, I would like to look for any mass, lumps, pain, tenderness, and then I would also like to do a speculum examination to look for the local pathologies, the vagina, look for the vaginal lesions, cervical lesions, and also the do a bimanual pelvic examination to look for the size of the uterus and also any lesions which are coming and look for the fornices, whether they are having fullness and deep tenderness and anything specific in terms of malignancy or infections or atrophy, or is it atrophic vaginitis. Then if everything is negative and if we still have
Okay.
any suspicion of character.
So yeah.
Mhm.
So here you stop here because I asked you specific history and examination. Okay. I'll mute you for now, Chaitha. Let's go through your answer. So when you were answering, I was highlighting in green what you covered. So you wanted to know about the bleeding. So I've written here, the bleeding started 7.5 years after the menopause. She describes her bleeding initially as occasional spotting, but then became as a period, which has been on and off for the past year. She presented to her GP 5 months ago with the bleeding. The bleeding is not associated with any pain, her smear history has been fine. So what you missed here was the smear history. Okay, so the initial, if you were asked this patient, if you were to ask her an open-ended question at the beginning, can you tell me about your bleeding? And that was a counseling station. She will tell you everything that's mentioned in the first 2 lines, that when it started, been on and off, how heavy it was, and when she went to her GP. That's why I've mentioned all of that information. Now we're going to close it off to see if there's any pain with the bleeding and her smear history. So don't forget, smear history is very important. Okay, you then went to the sexual history. So she's sexually active with her partner, no postcoital bleeding or dyspareunia. So you wanted to know postcoital bleeding and dyspareunia. One of your differentials, what you said it's less likely, but it was one of your differentials, STI. Just ask any abnormal vaginal discharge. Okay, any current abnormal vaginal discharge. Now you went down to medical history. Now what's positive here is that she's diabetic for the 10 years on metformin tablets. You wanted to inquire about any symptoms of cancer, bowel, urinary problems, weight loss, or loss of appetite. You then covered the drug history, any current medication, any allergy. And then you skipped and went to the examination. So complete the whole history. Family history, and you specified good. Family history of cancer, that's what's relevant. Family history of cancer or bleeding disorders, that can be relevant as well. And then social history in terms of her smoking habits, alcohol, recreational drugs, what she does for the living, and her support. Yes, Moniza, obstetric history. Thank you for writing that down. Obstetric history here is very important. But then I skipped it here because it's already mentioned in the letter. Para 4, all by normal vaginal deliveries. Okay, but yes, you're right, it's relevant. Now, examination, well done. I was focusing on the way that you mentioned your answer, so it was perfect. You adopt that way in any structured discussion. Don't forget the BMI. BMI has an impact on the treatment later on. Okay, whether it's cancer, whether it's endometrial hyperplasia, whether it's endometrial polyp, even if it just turns out to be an endometrial polyp, at the end you would advise weight loss just for her not to have what is it called, less operative complications. Okay, so abdominal examination, soft, no mass is felt. Bimanual, vulva is normal, vagina is atrophic. It can be expected in such an age group, but then again, don't just focus on that. The reason would be atrophic vaginitis, because given the duration and the amount of bleeding, and she doesn't have any dyspareunia or postcoital bleeding, it's highly unlikely that that's the reason for her bleeding. Uterus retroverted, not bulky, no adnexial mass is felt. So that's how you would justify your bimanual, to do bimanual examination to feel the vulva. Sorry, to look. So I'll start by inspecting the vulva for any abnormalities. I would then do a bimanual examination to feel the vagina, and the size and the mobility of the uterus, and to feel if there's any adnexal masses or tenderness. But then we'll proceed with the perspective examination to visualize the cervix, see if there's any abnormality, if I can see any bleeding at that time, and if there's any discharge. If there's discharge, I will take what is it called? A sample. Okay, someone wrote something here. He said, Mandu, you mentioned cervix is normal. What do we mean? What do you mean? I'll unmute you in a bit to explain your question. So you just, in the spectrum examination, you just mentioned that you would want to visualize the cervix for any abnormality. Okay, but here in her, so here, this is not the answer, Chaitra. Okay, I got your question now. No, these are the findings that me as an examiner, I'm going to give you after you mention your history and examination, so you can proceed to the next, answering the next question after you find the findings. You read the findings. This is not the answer. Okay, this is the history that I'm going to give you. Okay, and the examination findings that I'm going to give you for you to read, so you can have an idea and for you to know what you're going to do next for this patient. Okay, so no, you don't say cervix looks normal, all that. You just say speculum examination to visualize the cervix and to see if there's any bleeding or any abnormal discharge. Okay. Now, at this point here, I'm going to ask, so I've given the findings. Now, again, we go through it together. So what you were going to conclude when you read, so in the exam, you read it very quickly. Don't, a minute maximum or even less than a minute to go through the findings. Okay, so you know that it's been on and off for the past year, no pain, no postcoital bleeding or dyspareunia, no family, no high risk for cancer in the history that you can pick up at the moment. Okay, and examination, you just pick up she has a high BMI and everything looks kind of normal on examination. So you still didn't have an idea yet regarding what can be the possible reasons. So what my next question would be, what would be your next step? You examine this patient in the clinic, what are you going to offer her next? And that would be basically in terms of investigation. Chaitra, do you want to answer the question?
Yes, ma'am. I would continue. We
Yeah.
would like to do a complete blood count.
Mhm,
Then we would also like to know the general well-being of the patient by doing the blood pressure examination.
mhm.
Then, if BMI was not done earlier, we would like to know the BMI. Then we would like to know the ultrasonography of the abdomen and pelvis. And we would also like to know the cervical smear. If not done before, would like to do the cervical smear. Then, if the
Okay. Now,
ultrasonography,
when you talk about, when you mention you want to do an ultrasound scan, justify what's your aim of doing an ultrasound scan? What are you
yes,
looking
yes. Okay. Ultrasonography to see the size of the uterus, so see the lining of the endometrium, whether it is thickened more than 4 millimeter will be taken as abnormal in postmenopausal ladies. And if there is any focal lesions, if any, in the endometrium, or I also would like to see the cervical echo texture if there is any focal lesions in the cervix to rule out the cervical carcinoma. Then, if any of these are not
what
clear on the
else?
abdominal scan, we would also
Yeah, what else would you
add,
visualize on the scan?
yeah, we would also do a transvaginal sonography to look for any of the above mentioned lesion. And other than that, if there are any fibroids or any other adnexal masses which can be contributing to the similar history, like ovarian tumors, um,
Okay,
estrogen secreting ovarian tumors, then
okay,
anything other than this, like bladder and rectum. Yes.
okay. So you're gonna order for investigation. So you said the full blood count. You're gonna request that on the system. You're also gonna request for a scan. The scan, when you request it, it can take months until there's a slot available. What, and she's postmenopausal and complaining of bleeding. Anything special you're gonna mention when you're gonna order the scan?
Fast tracking. We have to do it within 2 weeks to
Okay.
rule out. Um,
All right.
yes.
Thank you so much, Chaitra. Well done. I'll mute you for now. So you know the answer. I just had to prompt you a little bit. Okay. So here, after you've examined and you've got the findings of history examination, the next step would be ordering for investigation. So when you mention the full blood count, you want to justify what you're looking for. Here, what would be relevant would be her hemoglobin and platelet. These are more relevant because hemoglobin, she's already anemic and she's on ferrous sulfate tablet just to make sure and check her hemoglobin levels. Platelet can help you with, finding any generalized reason for her bleeding. Also, a full clotting screen, since you're already going to order for a blood test, add it to it just to see if there's any clotting problems. Although it's highly unlikely if she had a clotting problem, it would appear now. It would be more relevant thinking along that line if already she had her periods, they were quite heavy. Okay, she always had that history of heavy periods before. Now, when ordering for a scan, you kind of went into too much details. That can waste a little bit of time, Chaitra. So when mentioning a scan, so you can say, I would like to order for a pelvic ultrasound scan. Since she has a high BMI of 40, preferably a transvaginal scan, which would give us a better view. I would like to know the size of the uterus, the endometrial thickness, and look at both right and left ovaries for any masses. That's your aim. That's what you'd be looking for. That's what you're thinking about. Okay. And you have to say I'm going to fast track it to be done within 2 weeks since she's a case of postmenopausal bleeding. Now, there's something relevant here that requires you to cover. She presented to her GP 5 months ago with the bleeding, and she's just being seen now in the clinic. That GP, she's a case of postmenopausal bleeding. That GP should have fast tracked that patient to clinic, because if GPs refer patients normally to a clinic, it can take months and months, sometimes up to a year, for them to have an appointment and come in. GPs are instructed whenever they suspect cancer and they have certain gynecological criteria, that's in terms of, if I'm talking about gynecology only, when to fast track those patients and send them to be reviewed within 2 weeks. And there's a special form for that. So here, when you go through the findings and then you go to your investigations, even before going to the investigations, you can cover that part, or at any point, as long as you cover it. Say that this patient, it took her 5 months for her to be seen in clinic from the first time she saw the GP. So I'd like to incident report this as she wasn't fast tracked. Okay? So you have to incident report it and look into it. So just in case, if there are any other high risk patients, I mean, if it turns out for her to have cancer, then there was a delay in her diagnosis from the time she presented. Any postmenopausal bleeding, you fast track them until the point when you exclude cancer, then you're going to take her off the fast track. So this patient, until she has the hysteroscopy and biopsy, she's going to be fast tracked. Everything's going to be done within 2 weeks' time. When the result of the biopsy comes out as not cancerous, just say endometrial hyperplasia without atypia, then you'll take her off the fast track. She can be seen whenever there's appointment available. Okay. Now, Chaitra, I want you to remember this point that I just mentioned about fast tracking when I give you the findings and ask you the next question. So that's her full butt count, clotting screen, and her scan. So the scan, the uterus, normal in measurement, endometrium measures 11 millimeter, regular in outline, 3 by 3 centimeters subservosal fibroid, normal light and left ovaries, no free fluid in the pouch of Douglas or masses. At this stage, my question would be, what is your differential diagnosis? Now you're going to narrow down the differential diagnosis that you mentioned at the beginning according to the scan findings. Think about your differential diagnosis for thick endometrium. After you mention your differential diagnosis, tell me what are you going to do next to be able to know what exactly is the reason for the bleeding, or in other words, the thick endometrium. Twice gone offline, I think, for a reason. Anyone wants to answer this question? Say less than 30 seconds, you can mention your answer. Anyone, please? Let me see if someone has written anything on the group. Sometimes some of you type there. Anyone? If you have a thick endometrial lining, what is your differential diagnosis? Tyther, can you unmute and answer this question, please?
Yes, ma'am. At this stage, we would think of one is looking at the high BMI and the features of prolonged persistent bleeding. First, we would like to rule out endometrial carcinoma, and then we would also keep other possibilities of cervical intraepithelial lesion or cervical carcinoma in mind. And then, depending on the ultrasound findings,
Okay,
oh,
so here,
madam
Chaitra, I gave
Sare.
you the scan findings. Okay, yeah. Go through the scan findings and tell me what is your differential diagnosis here.
Okay, looking at the ultrasound, the hemoglobin is normal. The patient is 9.8. That is normal.
I think Chaitra, there's a problem with your connection. Hello?
Aspiration biopsy outpatient basis.
Okay, sorry, your voice was interrupting. Can you
Um,
just repeat it again?
yeah, ma'am. Keeping in mind the high risk factor of BMI 40 and endometrial thickness of 11 millimeter, we would like to offer the patient an endometrial aspiration biopsy in the outpatient since it's a regular endometrium and not having any focal lesions.
Okay, what is your differentials for the thick endometrium?
Endometrial, yeah, it could be endometrial hyperplasia or it could be endometrial carcinoma also.
Okay, so you're going to book her in for a hysteroscopy outpatient. Anything special you're going to do when you're booking her in?
Ma'am, I would like to offer an endometrial aspiration biopsy. Is that okay?
Yeah,
Because there is no focal lesions. So,
yeah. Okay, so you can offer her a papal biopsy. If the patient refuses, then you go ahead with a hysteroscopy. It can be outpatient or inpatient depending on the patient's choice. Now, again, the same as with the scan, when you book her for even if it's an outpatient hysteroscopy, it's going to take
mhm.
time. So, what are you going to do?
Okay. For even for hysteroscopy, we will have to fast track her with a specific in the form request form
Yeah,
within two
okay.
weeks of date.
Yeah, okay. Thank you so much, Chaitra. I'll mute you for now. Well done. Also, Manikam, you answered here on the chat box. So you mentioned again, yeah, endometrial hyperplasia with or without atypia, endometrial cancer. Don't forget, it can be an endometrial polyp as well. Okay, that's why when the next step would be taking and we can offer her papal biopsy in clinic. If she refuses, she needs to be booked in for a hysteroscopy and endometrial biopsy plus or minus polypectomy. It can be done as an outpatient or an inpatient depending on the patient's preferences. Okay, so you don't limit yourself to an outpatient. Patient can say no, I would want an inpatient. And I would like to fast track her as well for the hysteroscopy. Again, there's a special form for either inpatient or outpatient hysteroscopy for those in which you're suspecting they have cancer. Okay. So the patient underwent an inpatient hysteroscopy and biopsy. This is the result. Now again, it's endometrial. It's the same result that was there for the counseling station that we did first. Okay. It shows endometrial hyperplasia without atypia. So let's just connect the dots together and the relevant points that you would need to cover in your management plan. Because when you answer this last question regarding your management plan, you will be marked on your applied clinical knowledge, on your patient safety and communication with colleagues. Okay, so if I highlight here, so the relevant things that you're going to bear in mind in your management plan, that she's diabetic, cover that. She's a smoker, cover that. She has a high BMI, cover that. When you're covering it, communicate with the colleagues because that's where you would be marked. Okay. And then after that, you have that she has endometrial hyperplasia without atypia. Chaitra, you can proceed since you started. So tell me, how would you manage?
Yes. Um, I would like to offer her uh, Marina coil, which is a progesterone device, which is a T-shaped device which will be put inside the uterus, and it usually acts by thinning the endometrium further, and it's usually takes 3 to 6 months to adjust to the body status. Intermittent bleeding can be there, and sometimes cramps, and very rarely expulsion can also occur. I would like to warn about these things to the patient. And some patients do have what is called as bloatedness, weight gain sensation, and headache if they have a past history of migraine. I would warn the patient about all these things, and if she agrees for the Marina coil, we would like to go ahead and insert Marina coil in the outpatient basis as soon as possible after consent. Then I would also like give her advice about the weight reduction program, and would refer her to the obesity clinic where she'll be taken care with the dietitian and the physiotherapist, and would be followed up for the weight loss program. Then her smoking status, we would encourage her to quit smoking. I would refer her to NHS Stop Smoking Center for further rehabilitation. Then, since she's running low blood counts like hemoglobin 98 gram per dl, we would like to rectify it with oral iron therapy to improve her quality of life. If the patient refuses Marina coil, or she
Okay, before
doesn't
you
want
go
any
ahead,
invasive,
Chaitra, before you go ahead with the next option, cover the follow-up of the Marina coil. For how
yes,
long
ma'am,
it's
yes.
going to be.
Yeah, we would like to follow her up every 6 monthly with the endometrial lining by vaginal scanning, and then endometrial biopsy too. Every 6 months, at least two samples. If it comes negative, we would like to put her into the yearly follow-up, annual follow-up till lifetime. Then otherwise, if the patient develops any other symptoms like excessive bleeding in between, or the features of endometrial biopsy shows relapse of the hyperplasia, or hyperplasia becoming atypia or abnormal malignant cells, then we would like to give her the other option of definitive treatment of abdominal hysterectomy with bilateral salpingo oophorectomy, which we would like to do in the laparoscopic approach. Since her BMI is higher side, she is a high risk category. We would like to take all the precautions of thromboprophylaxis, and also would like to have a weight reduction before planning for the surgery. Then
Yeah, if the patient refuses
this
the
is
coil,
if the patient refuses the coil, we would like her to give the second option of oral progesterone therapy, either medroxyprogesterone acetate 10 mg twice daily, or norethistérone. Both are acceptable, but we have to warn her that she has a higher side effect with the oral progesterone therapy, and the regression of this endometrial hyperplasia to normal cells will be low compared to the levonorgestrel intrauterine system. Um, and the regression rate of oral progesterone will be 85%, so which is less than the Marina coil. So the chances of continuing the therapy for prolonged duration also to be mentioned, and the chances of progression and hysterectomy may be more with the oral progesterone therapy.
okay, thank you so much, Shaitra. Well done, and Ruchi for now. Excellent answer and very concise. You even answered the last question that I was going to ask, which is when would you consider the need for a total abdominal hysterectomy? Okay, so I had to stop you just to cover the follow-up. So always, as you're going to do in a counseling station, when you start with an option, show the rest of your knowledge, cover, yeah, the risks, the side effects, and cover the follow-up. You also covered safety in terms of what warning advice you will give the patient and when you're going to proceed with the option of a hysterectomy. You involved colleagues by controlling other risk factors such as a high BMI and giving smoking advice. Okay, and also ensuring that her diabetes is well controlled. Okay. Right. So so that's the end of our case scenario here. This one. Does anyone have any questions here? Okay. Do we give patient, do we need, so try to ask, do we have to confirm patient name and NHS number here? Okay, that's a good relevant point. What you can mention in a structured discussion if you have findings, let me go backwards. So you can say, let's say I gave you the results, say after confirming it belongs to the patient, she has endometrial hyperplasia without atypia. My management plan would be, and then you start talking. So yes, you just show the examiner that if you have the patient's name and age or NHS number, you mention it, or sometimes hospital number. Okay. All right. Now, I have 2 more stations left, but then again, I would require volunteers here. Okay. And I do understand that some of you may be hesitant or skeptical in performing a case without really preparing beforehand. Okay. So we have 2 cases, and one from antenatal care module and one for management of labor and delivery module. Okay. One is the one from antenatal care module is a high risk Down syndrome screening test result. Now that's quite normal, but it's just I put it, it's a straightforward case scenario, but I put it just because the way you explain the screening test. Okay. And the next one is a lady high risk, one previous cesarean section scar requesting home birth, and that requires special communication skills here. Okay, so we started off with a normal counseling scenario, but then I wanted to finish off with a case that in which just show you how to approach short case scenarios, because it will be quite different when a patient is demanding or requesting something that is not advised. Would you like to continue today, or would you like me to schedule another session to cover these 2 cases? Because I understand some of, here in the UK it's 5:30 p.m., but I know that it may be almost midnight in other countries. So just be voting and let me know what you think. You can write on the Telegram group or just write it here.